Welcome everyone to Truth in Dentistry with me, Dr. Paul Belzicki, where we endeavor to deliver honest and efficacious information in the pursuit of excellence. Hello everyone and welcome back. As I stated in another post, I basically created this channel where I would park some 25 mentorship lectures that I had done in conjunction with the Canadian Dental Association. Not really thinking I would ever be an active participant in this, and I did that about 4 years ago. And some months ago, I got an email from someone claiming to be a young dentist in Algeria who had viewed many of these presentations, and he wanted some information, some advice on how to treat cases. And originally, being quite skeptical, I thought it's probably just some overseas web designer who just wants to redesign my website. And I thought I'd better have a Zoom meeting with him, and I would prepare some questions that only a dentist would know how to answer, or at least engage in a conversation where I would figure out, was he a dentist or was he not a dentist? And he passed with flying colors. He's a young dentist, graduated some 3-4 years ago in Algeria, and he claims that on my other presentations, he sees protocols that he wasn't really exposed to and that aren't practiced by the senior dentist that he's working for. So in that vein, I thought I'd be more motivated to make some more presentations, and recently he asked for me to compare conventional crowns, as I like to do, versus Inlay Onlays, which are the composite resins that are milled and done indirectly. So this presentation is my attempt to answer those questions. And I'm trying to gear this not only for dentists who I hope are watching, but also for the general public. So we'll look at some cases together and I'll give you my point of view. Here we go. So with that in mind, let's discuss conventional crowns versus bonded inlays or onlays, and I would assume these would be tooth-colored as depicted here, some sort of resin glass substrate. So for those of you that are not dentists, I will outline these restorations, and these are typically indirectly made restorations. They're made either off of a study model or they're made off of a computer scan. And an inlay is some restoration that's placed within the confines of the tooth. This could be a filling. With something this small, I see no reason to go with an indirect restoration. You might as well just put in some sort of filling directly into the mouth. This is an onlay. It would be used if, say, some cuspal structure broke away. The cusps are the part of the tooth that do a lot of the grinding, like a mortar and pestle. And restoring this, if it's broken, you need some sort of restoration that will cover it. And so that's an onlay. This is termed a crown, but it really isn't. It's just a more extensive onlay where both the lingual cusps and the buccal cusps are covered. So 2 onlays, 1 inlay. Indirect restorations made outside of the mouth. So typically, if some part of a tooth may have broken and the tooth is prepared, more tooth structure is removed. It looked like this to begin with. This is the way the tooth was prepared. And then the indirect restoration is then bonded on top of the tooth. So this is an onlay of some form. And this is an inlay. Again, hollowed out area is prepared. I've highlighted there. And then this little restoration will be glued into place, will be bonded into place. Now, there is the claim that this has the advantage of being conservative dentistry. You're not taking away a lot of tooth structure that you would for a crown. You're just taking away a little bit and bonding something on. And that material is typically some sort of resin polymer, some sort of glass or porcelain substrate. And these are inherently weak materials. You can pick it up with your fingers. If you bend it enough, it'll snap. And these restorations are to be bonded to the tooth structure with the hope that the tooth will provide mechanical support to the restoration. That's how these things function. So on a study model, I'm fond of saying everything looks perfect. Everything looks possible. On a computer screen, particularly if you go to some of these sites that promote it, you'll see animated teeth with animated drills and animated drilling, and filling flies in and gets popped onto the tooth. And on a computer screen, everything looks perfect. Everything looks wonderful. But what about the harsh environment of the oral cavity? When I put in indirect restorations, when crowns come back and they're sitting on the bench, and the patient looks at it and they'll say, "Hey doc, how long will these last?" And I typically will say, on the study model, these things will last forever, never break. But once you put them in the mouth, all bets are off, because biting, chewing, clenching, wear and tear, cyclic fatigue over the years, restorations can break. They just can't fatigue. So therefore, I question the long-term durability of these materials, given that the material is not durable. It's not robust. Here is a patient, here's a case, where on this tooth we have a gold onlay. It's really a 3/4 crown, but we can consider it an onlay. It covers the cuspal structure. And that crown, that onlay, has been in place for 50 years. I didn't do this. I've only been in practice for 45 years, but some dentists, prior to this patient coming to see me, they put in 2 crowns that are over 50 years old, and that's still in place. As opposed to this composite or resin or some material, and it was lab processed, it was milled, patient told me, ceramic onlay is less than 3 years old, and it snapped and broke. Lost faith in that other dentist and came to see me. And that's the part that broke. Again, I'm trying to address this to dentists as well as non-dentists. So those of you that are dentists, please be patient. And that's the part that broke. Again, it's this sort of an affair. It was an onlay, and that fragment broke away on that tooth. And there you can see it. So resins and porcelains, glasses of a sort, lithium disilicate, things of that sort, are inherently weak materials. They have to be properly bonded to tooth structure because they get their strength from the tooth. Resins and porcelains are not equivalent to metal. Gold, we call it the gold standard. Why? It lasts for decades. I have 2 gold crowns similar to this in my mouth. One's 40 years old, one's 35 years old. I can eat nuts. I was going to say bolts. I can eat nuts and bolts and ice and whatever I want, chicken bones, any kind of bones. They've given service for 4 decades. So I prefer full coverage with crowns. Crowns provide long-term durability in terms of decades. But the caveat is they have to be properly designed and fabricated. So I'd like to go into that. With a case, this is a recent case, just finishing this up. And this is I'd like to talk about the design and fabrication of a conventional crown. So this patient has come from the Ukraine. She had a resin filling put on that tooth, on the first molar. It's from the Ukraine. I don't know what materials they've had there. Obviously, we do have better looking materials here, but it is an old resin filling. And there's decay in that tooth, and there's a little bit of decay in that tooth. Now, when I looked at this tooth, this is all hollowed out, big filling in it. She says it's bothering a little bit when she bites. And the cuspal structure has been ground away to place that filling, so I know I'm dealing with weak surrounding tooth structure. On the x-ray, for those that are non-dentists, I will just highlight the enamel, blinking on and off. So most of the tooth is covered with a hard structure called enamel. It's crystalline in structure, 95% mineral, and it's non-living. It'll crack, it'll break, and it is supported by an underlying material called dentin. Dentin is a bony-like material. It's alive, it's living, it's 65% mineralized, and that's what a tooth looks like on a radiograph. And in the middle of the tooth is big red. That's the nerve of the tooth, the pulp. And we would like to avoid violating that when we're doing restorative dentistry, when we're cutting into a tooth, trimming a tooth for a crown. We do not want to injure the nerve of a tooth, otherwise we're in the realm of root canals. Now here I'm highlighting where the filling is, the composite filling, that's right there. And there's the nerve of the tooth, and there's some decay. We can pick that up on the radiograph. So I know this tooth, there's too much gone to put in another filling. The walls of the tooth are thin, and once I cut out this filling, they'll be even thinner. And that's exactly what happened. First things first, I addressed the decay that's in this tooth, and I put in a silver amalgam, silver filling. I love amalgam. Amalgam, I'll put this filling in, I won't have to touch this tooth for 30, 40 years. And if you will, this is an inlay. It's a direct inlay. Mixed up the amalgam material, put it in there, it hardens. And this robust filling material will give service for a lifetime. As opposed to composite resin, which doesn't. The literature says that. It's in every dental materials textbook at every university level dental school. Nothing compares to amalgam in terms of a direct restorative material, except of course gold foil, which I did a lifetime ago, don't do those anymore. So that's what decay looks like. The dentin is brown and dark. So I've got to cut some of that away, and I can see these walls are getting thinner and thinner and thinner. And to ask this tooth to support a large filling that close to the pulp chamber, I didn't think that was a good recipe for success. So I trimmed this down for a crown. And what we do is shave it down to the shape of a cylinder. And there wasn't enough tooth structure for a properly designed crown preparation. So I sunk in 3 TMS pins, self-shearing, self-retentive pins, and half stick in the tooth, half stick out of the tooth. There you can see them. Put a band on the tooth, put in a filling, carve that filling up, and this is a proper crown prep. Here it is from the lingual. And a provisional crown is put on top of this tooth. So a properly designed crown reinforces the remaining tooth structure. So essentially this is like a thimble. When the patient bites down on this, stacking cups or a thimble, when she bites down, all the forces have strapped up that tooth and it's holding the tooth together. As opposed to a cusp coming down in this area, grinding back and forth, these cusps have to be sturdy enough to withstand lateral pressures, lateral force vectors. This is entombed in a thimble or a cylinder, and that tooth is now secured. Thereby, it's ensuring long-term durability. And this is an indirect lab process crown. So an impression is taken. I'm not in the realm of digital. I'm still working off of stone models, and I will for the rest of my days because that's what works in my hands. So a stone model is fabricated, and an accurate impression is taken, and it has to mimic or it has to replicate what I've carved in the mouth. Design, the anatomy of the crown preparation is vitally important. We have to have slightly converging axial walls. because we don't want any undercuts, but we want them slightly converging and of a good length, because long axial walls provide resistance and retention form so that the crown doesn't dislodge. It can't be too pointy. I'm sure that's self-evident, as opposed to this little bicuspid here, where the crown or bridge that was on there had fallen off within less than a year. Somebody did not give full attention to the fact that the axial walls were not long enough. So a crown prep, when somebody says a crown, I'm making a crown, not all crowns are created equal. Not all crown preps are created equal. You might want to call this a crown prep. I don't. This is bad operative dentistry. And there's the loose cement was beginning to degrade. So that was a failure within a year. So somebody says, oh, you know, you put a crown on my tooth, you put a bridge on a tooth, and it failed. They're no good. They're good. It's the work was no good. But properly executed dentistry will last. The second thing that we worry about is the margin, the finish line, which is where we stop drilling. We call this the margin. And that has to be accurately captured in the stone model, because that marginal seal is critically important, because it prevents the ingress of bacteria and oral fluids, which will wash out cement that I just showed you at that other picture. So this is a crown. It's a porcelain fused to metal crown or porcelain bonded to metal crown. There's a metal substructure. There's a metal thimble. And we wanted something aesthetically pleasing, so porcelain is baked onto that. Now, porcelain is weak, as I said before, but it gets its strength from being bonded to a metal substructure. Porcelain fused to metal crowns are aesthetically pleasing, yet they're durable, which is why I employ them. So here you can see the underside. This is the interior surface. Our crown margin has to be faithfully replicated on this stone model for it to be successful. So securing long-term retention. This is the day I prepared the tooth. Yes, I know I've beat up the tissue a little bit in that area, but after an hour or two of crown preparation, getting proper ferrule, the tissue got beat up, but with a proper fitting crown, within a week or two, the tissue comes back and we have epithelialized skin. And there it is from the lingual. Day of insertion, there's the crown, fill it with cement, pop it on. Now, I have fixed these 3 teeth, and I fixed these 3 teeth for decades, because that's been my experience. These amalgam restorations will be durable. They won't wear away in a heavy occlusion the way composite resin will. Yeah, composite resin looks good the day you put it in, but years later, there's a lot of wear and tear. Amalgam will just hold up to all of that, and there's that crown. Yes, porcelain can break, I understand that, but if I get 2 or 3 or 4 a year, it's a lot. If it's properly managed and the lab knows what they're doing and it's fired properly, a porcelain fused to metal crown will last. And the best part about it is it reinforces the weakened tooth structure that was underneath. So I've given the patient a restoration that will last decades, if not a lifetime. So you say to me, well, how can I make this claim? Here's a case. Again, this is recent, within the last month or so. I graduated in '79. In 1980, I bought a practice, and this patient came to me in 1982. About my age at the time. She had crowding issues. She had 4 front teeth that she didn't like. Treatment plan was made up. Somebody took her 4 incisors out, made her a partial denture. And she hated this partial denture from the second it was inserted. And I don't blame her. So she had orthodontic issues, crowding issues, malaligned teeth. Again, 1982. These are off of Ektachrome slides. We didn't have computers back then. So I thought, well, if we could take out those bicuspids and send her off to an orthodontist and get things aligned better, close up some spaces, I might be able to use these eye teeth, these cuspid teeth, as retainers, which are basically just crowns, crown preparations, but there'll be a string of fake teeth attached to them. And here it is, some 20 years later, 2004. And these are the original amalgam restorations that somebody else had placed. I didn't place those, but they never gave any trouble. So there it is, 20 years later. There's that bridge. And I had noticed there's a little crack here. So a solder joint had yielded, had given way, and it had broken. So I had to replace this bridge. Here you can see I've put, back in 1984, 85, I put 2 crowns on this side, 2 crowns on that side. Went with full gold because at the time she lacked anterior guidance, heavy occlusion on the molars, and she had a lot of living to do. And I thought porcelain may crack, porcelain may break. And given the wonderful aesthetics of this bridge, she said, yeah, you want to go ahead and make metal crowns here? Go right ahead. I'm happy. You gave me a nice smile. So those crowns, those full gold crowns, have been in place for 20 years. There you can see them. 20 years of service. So back in 2004, I cut the bridge off by sectioning through these retainers, or crowns if you will, where there's a string of fake teeth attached to them. But basically these are crown preps. But because teeth are attached, we call them retainers. And you can see the cement is still intact in these retainers. And the teeth look like the day I put them in. And I always say to people, if I do my job right and the lab does their job right, if there's ever a problem, we'll cut it off. It's just exchanging hardware. And that's what we did. We remade the bridge, inserted it in 2004, and there you can see it. And the crowns are still in place. But some 20 years on, now it's 2023, and just physiological recession over the course of a lifetime of brushing, diligent brusher, great oral hygiene. Yes, she's milled some toothbrush abrasion notches and chased the skin down a little bit. 75 years old, teeth are still going strong. And she said to me, oh, there is the upper arch. Over that 20 years between 2003 or 4 to the current date, I did place 2 crowns on those 2 teeth. There were problems, perhaps a cusp or something had broken. So 4 porcelain fused to metal crowns were put in, and that arch looks beautiful compared to what it was 40 some odd years ago. So I've given a service. And when I look at this, I'm still passionate about doing dentistry. When I look at these photographs, and I take so many of them, I'm just amazed. I'm just amazed what my hands have done, what my talented lab technicians have done for my patients. It just gives me a lot of satisfaction to look at these things. But she said to me, before you retire, could you please make my lower teeth look nicer? I mean, you've done such a great job with the upper. I'm tired of looking at this gold. I said, well, look, when you're ready, let me know. And she came in this year, July, not too long ago, and let's replace the 4 crowns. So I cut off the crown on one tooth, and then I cut off the crown on the other tooth. And again, looks like the day I cemented them in. These crowns have been sitting on these teeth for 40 years. And that, my friends, is an amalgam core buildup pin retained. So those of you that thought from that previous picture, oh, you put in pins, you put in amalgam, she's going to die, you know, she hasn't died yet. This restoration, pin retained amalgam core buildups are my go-to restorations when I'm doing crowns on badly broken down teeth. Here it is from the lingual. Just nicked a little bit of it when I was sectioning the crown to remove it. But that looks wonderful after 40 years. And here's the cement. This is the interior of those crowns. And it's a cement called Poly-F+. I've been using it my entire career. It's a polycarboxylate cement. It's made by Dentsply, at least it is now. I don't know who made it at the beginning. Manufacturers buy one another out. But this is a wonderful material. Having said that, I'm sure that Dentsply will probably stop making it shortly because that's just how things are. All these great materials, folks aren't making them anymore. I also use Keytac glass ionomer cement, the traditional powder liquid cement. Mostly I'll use polycarboxylate cement, sometimes Keytac cement. The odd time with zirconia crowns, I will use Reliax Unisem, that's also a 3M product. But most of the cement I use on a day-to-day basis for metal substructure, for metal substrates, will be Poly-F cement, because it's proven itself decade after decade after decade. And again, if I do my job correctly, and the lab does, the cement looks as good as the day of insertion. So there are the teeth. The notches are present from toothbrush abrasion. There's the old margin. So what I had planned to do was just trim down to entomb that defect in a new crown. There's the crown preparation, there's the impression, and if we zoom in, I will tell you that this impression is perfect. You can see the margins 360. There are the provisionals, there's the stone model, replicating what I had carved. Again, here are there's the bottom end of those pins, and the teeth look perfect. Carved margin, and there are the crowns. And those crowns, porcelain fused to metal, are cemented in place. At the age of 70, 75, these will take her the rest of her days. I doubt if she'll break them. Yes, sometimes with that metal margin, let me just go back for a second. I like leaving a metal margin in areas where aesthetics is not an important issue, because a metal margin is cast, it can be polished and burnished to fit perfectly. I want to put this in the mouth before I cement it in. I take a fine explorer, I run from tooth to margin to metal, and I don't want to feel anything. If I feel something, it's going to go back and get remade. Something was wrong. So these fit and seal up a tooth very, very predictably. In an aesthetic area or higher aesthetic demands, I will do porcelain over metal. And if it's a very high demand, such as the anterior segment, I will go with zirconia. Zirconia has proven itself to be a very durable material. But the most faith I have is first full gold, and then porcelain fused to metal, and then zirconia. We decided to do the left side as well. Cut those crowns off. Again, teeth look like the day I prepped them. Those little gouges are from cutting through the crown. Here are those crowns, and the cement looks like the day I put it in. Poly-F+, polycarboxylate cement, developed by Dennis Smith here in Toronto a lifetime ago. I put the cord in, and the second I got the cord in, we got a power failure in the building. And it lasted hours, so I had to go across the street, drag the patient across the street to a colleague of mine, Dr. Andrew Moncars. Thankfully, he gave me an operatory so I could put provisional crowns on these teeth, and she'll come back and I'll have to prepare the teeth another day. So conventional crowns versus resin glass inlay onlays. Here is a mouthful of crowns. The front segment was done in 1989. This is 1984, 92, 95, 90, 84. And they were done at different times. When a tooth broke, patient had heavily restored teeth. And I told her, when they broke, when you have a problem, we'll just do one tooth at a time, and we'll see where it takes us. And over the course of 4 decades, she's still with me. That's what I've done for her. Those are all porcelain fused to metal crowns, and she just has a few on the bottom. I'm waiting for these to break so I can do something, but if it's not broken, there's no need to fix it. And most of these teeth required endodontic therapy. It wasn't done prophylactically. There was a need. There was either pain, discomfort, or for restorative reasons. So these were done in 89, the anterior segment, that bicuspid in 1984. These are the dates that the crowns were done, and you can see they span the 2 or 3 decades. I have witnessed that resin, glass, inlay onlays lack long-term durability. I see them come from other offices, don't want to do them myself. I see them come from other offices. The inlay may have broken, or typically, if they've covered just one cusp, it's the cusp that has not been onlayed that breaks away, and then I got to put a crown on them. So I don't understand. If you're cutting a tooth, taking an impression, doing all of that for an onlay inlay, which is not durable, I don't understand the thought process behind that. I'd rather just do it once, strap the tooth up in a crown, and never look at it again, or hardly ever look at it again. So as I said, I've got crowns in my mouth. So what to choose? You know my choice. I'm trying to drive a point home so those of you out there can make your choice effectively. And please, I don't need anybody to practice like me. I'm an island unto myself. I'm not setting myself up as a guru. I don't want to be a leader. I'm just trying to share how I've practiced and hope that somebody else will benefit from my knowledge. So inlay onlays, resin glass, lithium disilicate, or Empress. So these are inherently weak materials. They rely on the tooth for strength, as I showed earlier on. Crowns, whether they're full metal, porcelain fused to metal, or zirconia, these are strong. These are 2 zirconia crowns. They rely on a very tough, durable ceramic substrate, but it's still not metal. I've had these, not so much the substrate, not so much the core has broken, but there can be problems with the overlay porcelain. Porcelain fused to metal just takes a licking and keeps on ticking. And these are inherently strong materials. With inlay onlays, tooth provides mechanical support for the restoration. With a crown, crowns provide mechanical support for the tooth. The thought about being biomimetic. By that, I assume they mean mimicking what the tooth looks like. Well, these zirconia crowns, they mimic what a tooth looks like very, very nicely. And here are these 2 crowns for a patient of mine on these 2 teeth. This is porcelain fused to metal. Yes, there's that little dark metal collar. Here it's missing. So in terms of aesthetics and being biomimetic, it's biomimetic. And so are these porcelain fused to metal crowns. They look like teeth. As far as I'm concerned, gold is the most biomimetic. Yes, I understand it's gold. It doesn't look like enamel, it doesn't look like tooth structure. But nothing compares to full gold. If we consider mimicking something that's biological, gold is biocompatible and it's inert. It's a noble metal. It doesn't tarnish, it doesn't dissolve, it doesn't do anything. It's soft and ductile. In that regard, there's a lot of strength. It's robust. It won't crack. It won't break. Also important, because it's soft and ductile, as opposed to the porcelains, it does not abrade the opposing tooth structure, as other restorative materials might. So in terms of being biomimetic, and of course, best of all, the crowns protect the underlying teeth. So in terms of being biomimetic, I don't see anything more biomimetic than a properly made full gold crown, except for the color. Regarding what is more conservative? Well, yes, we have to grind away more tooth structure for a crown. But the tooth and the restoration remain stable for decades. So yes, the initial cost might be high, but it buys decades of security. If you take the cost of a crown, of a single crown, and amortize that over the 30 or 40 years that it might give service, I think a crown, dollar for dollar, is the most conservative, most cost-effective way to restore a badly broken down tooth. So expertly designed conventional crowns win, in my opinion. It's the most successful restoration, particularly if there's cuspal damage, and especially if the tooth has undergone endodontic therapy. You have to strap that up to prevent root fracture. So thanks for sticking to the end. I'm sorry if it got lengthy. I just cannot do short posts because when there's a topic that needs investigation, it takes time to draw out all the finer points. Thanks for sticking around, and I look forward to making another one. Bye-bye.